Hello, everybody, and welcome to this month's GaPQC Optimizing Newborn Nutrition webinar. Everything you always wanted to know about donor human milk, but were afraid to ask. First, we have a couple of updates for you all. You'll notice at the end of the webinar, we've included a QR code. When we get to that point, please scan that with your smartphone. We'll also drop a link in the chat if you don't have a smartphone to scan that with right now. And you'll go to a page where you'll enter your name, your hospital, and then if you're with a NICU team or mother-baby team. And that's going to help us kind of track the reach of our webinars. And if you're watching this in the future from a recording, either on Teams or on the website, please still follow that QR code and enter your information. And that way, even if you're not able to watch it live, we have record of you viewing the webinar at any point. This will be included on all webinars moving forward. So just a little information on why that's there. The Q4 reports were posted on Teams and links were sent out to the data leads for each team. If you are a data lead and you did not get that email, reach out to me because it definitely went out. It shows the July through December data. And if you go to the team site and go to audits, the collaborative folder is there and you can see the collaborative data, the report as well. That one's not password protected. All the hospital reports, individual reports are password protected. So if you're a data lead and you're trying to access your report and you need your password, just give me a quick email and I'll send that to you. Thanks to teams who submitted their SMART aims and driver diagrams. We have, I think, about half of teams that submitted their SMART aims, which is great. And but you can still submit it if you have not yet. If you're having questions about it or any trouble coming up with it, please let me know and I can connect you with members of our neonatal committee who will be happy, especially now that we have our July through December data out, to kind of walk through that report and narrow down some areas that could be a focus for you all for that SMART aim. Same with driver diagrams. Those are due March 1st. So if you have any questions there, you have a SMART aim and now you're working on your driver diagram, but you maybe have some questions, reach out to me. We can connect you with some neonatal committee members and walk through that as well. Some teams submitted their SMART aims and a driver diagram already, and they're really fantastic. And so we'll share those out. We'll take off any identifying information. I've already asked the team's permission and they're happy to share theirs just to see what other hospitals are working on. So maybe you have an idea, but you're not quite sure how to execute it and what that driver diagram would look like. We'll share some examples. And again, if you have questions, just reach out. A new train micro lesson was posted. It is on the basics of how pasteurized human donor milk is collected and processed. So if you were not able to view that micro lesson before today, please do after it goes great with today's webinar. The best way, the easiest way to access it is when you log on to Train, just search GaPQC in the search bar and you'll see our micro lessons come up and it'll be the ONN micro lesson number 3. If you're having any issues, reach out to me. In the follow-up email, I will send the kind of tool that we created for how to create a Train account if you don't have one yet and how to access the micro lessons on Train once you have an account. So that'll be great for new team members if you have any, if you're just having any trouble finding it. It's really great. It's short. It's this great 6-minute lecture, and then you come back, you view the lecture, come back and do a 5-minute, or excuse me, not 5-minute, 5-question multiple choice assessment. So make sure you do that assessment because that gives you the credit for completing the micro lesson. And finally, the Emory Conference on Breastfeeding, GaPQC will have sponsored registrations this year. It's back in person March 13th and 14th, so a month from now, and registration is open. And as I mentioned, GaPQC is sponsoring a limited number of registrations for participating hospital teams. In the follow-up email that I send out after the webinar, I'm going to include a code. You'll enter that code during the registration process, and that's when you'll see your total come down to 0. And this is for in-person attendance for the conference. We ask that teams only send one person using this code so we can support more representation across teams. Claire's going to drop the registration code in the chat, and we'll also send it up in that follow-up email along with the code. They also have an on-demand access to the full program. Access to that will go on sale soon. So for those of you who cannot attend live, you could do the on-demand portion. And if funds allow, after we support in-person registration, we can support some of the on-demand registration. So more information will come out on that as well. And there's many topics of interest to participants in this initiative that will be presented, including more on donor milk quality and safety, exclusive human milk diet in infants with congenital gastrointestinal disorders, the use of human milk in preterm infants, assessing breastfeeding documentation among providers, breastfeeding with HIV, ethics panel on supporting feeding goals when resources are scarce, and antenatal milk expression. Now we're going to move into our educational session for today. Our presenter and panel moderator today is Dr. Allison Rose. Dr. Allison Rose, a native of Atlanta, received her medical education and subsequent training in pediatrics and neonatal perinatal medicine at Emory University. She is an assistant professor of pediatrics and practicing neonatologist with Emory University and Children's Healthcare of Atlanta, and is the assistant medical director for the NICU at Grady Memorial Hospital. Her academic and research interests include the care of infants with necrotizing enterocolitis. She is interested in optimizing strategies to prevent NEC, which include improving the provision of human milk to fragile infants. In addition to working in the neonatal ICU, Dr. Rose is also involved in the Georgia chapter of the American Academy of Pediatrics legislative and breastfeeding committees to advocate for the health of Georgia's children, and led efforts locally to secure Medicaid reimbursement for the inpatient use of medically indicated donor human milk. Neither Dr. Rose nor our panel of experts have relevant financial disclosures. I'll hand it over to you, Dr. Rose.
Awesome. Thanks, Kimberly. Hey, y'all. Good afternoon. It's wonderful to be here. I'm really excited for especially the last part of this time together today in our open panel discussion, because I think that will be really, really interesting. And we're going to learn a lot about what we're doing. The objectives for today are first to review some common terminology and definitions, just so that we're all on the same page about what we're talking about. We're going to go over sort of current evidence for the use of donor human milk with some reference specifically to what the American Academy of Pediatrics has put out for us. And then, like I said, the last part of this talk is going to be an open panel discussion. So why is this important? And you can go to the next slide, Kimberly. Perfect. So why is this important? Why are we talking about donor milk? And the point is not to give donor milk to every baby. That is not the point of this. But it is to improve the exposure to human milk and to breast milk for our infants. And we know from our GaPQC audits that were done early on that more than 50% of infants at hospitals participating in GaPQC receive formula. And from the U.S. breastfeeding report card, we do know that Georgia is the 48th worst in the U.S. in terms of breastfed infants receiving formula before 2 days of age. So there's a lot of potential work for improvement here, and there is a role for donor milk in some of this. Next slide. One of the hospital baseline measures that GaPQC collected was around policies. And as you can see from this slide, about 64% of hospitals have a policy on donor milk, and only about 50% have a policy related to supplementation if supplementation is medically indicated. So there's also some work to be done here for hospitals in terms of identifying for whom they may want to use donor milk and for whom they may want to offer supplements when needed. Next slide. I'm going to talk about here first just a couple definitions, like I said, so that we're all on the same page. These definitions come directly from the 2021 American Academy of Pediatrics clinical report on the use of human milk in breastfeeding for very low birth weight infants. So mother's own milk is milk from an infant's own mother. It seems clear. Sometimes you may see this referred to as parent's milk as we are becoming aware of appropriate and ways to refer to this. Just for consistency and clarity throughout this talk, I will use mother's own milk. That is most commonly what is used in studies. So just to try to be consistent, but just so you know, you may see other terms for this. Next is pasteurized donor milk. So this is breast milk that has been donated to a milk bank and pasteurized to eliminate any pathogens. Next is informally shared milk, and this is now sometimes called community shared milk. This is unpasteurized milk from another infant's mother. So this is sort of direct sharing within the community without using a commercial milk bank. Next is just the terminology human milk. So if the terminology human milk is used, this really could be referring to either mother's own milk or pasteurized donor human milk. Next slide. So HMF, human milk fortifier, and there are typically two types. So bovine-derived human milk fortifier is going to be a cow's milk, protein-based nutritional fortifier of human milk, or you may hear referred to as human-derived human milk fortifier. Obviously, this is confusing, but this is human milk protein-based nutritional fortifier for human milk. And then if the terminology exclusive human milk diet is used, that is meaning that it is either mother's own milk or pasteurized donor human milk with a human-derived human milk fortifier. So that's just kind of a summary of the terms that are used in this space as we discuss what is used in the NICU and supplementation. All right, next slide. So there, as you all know, there are significant short and long-term benefits to mother and baby for feeding mother's own milk. And in preterm infants, studies have shown that when very low birth weight infants are fed mother's own milk, they have better neurodevelopmental outcomes, and they have less of all the bad comorbidities that are frequently associated with these small babies, including necrotizing enterocolitis, late onset sepsis, chronic lung disease, and retinopathy of prematurity. But while we know that mother's milk is essential to the nutritional care of preterm infants, there really are a ton of reasons why a preterm baby may not have access to mother's milk. And these involve both individual as well as systemic factors. So mothers who give birth to preterm infants or infants who require NICU care are often themselves medically ill, and so they may have reduced milk supply due to medical complications. Infants who require NICU care are typically in a special area of the hospital that is separate from the mother and the parents. And they're often in the hospital for months after the mother is already discharged. So the parents have to travel back and forth to the hospital to see their baby and to bring milk. And the tiniest of NICU babies, they can't nurse directly. They can't nurse directly at the breast. And so the mother has to establish lactation and maintain her milk supply solely through pumping. And we know that establishing an adequate milk supply is really crucial and is dependent on sort of early and frequent milk removal from the breast. So many premature babies are born in emergent and unexpected situations, and mothers haven't had the opportunity for any health education about breastfeeding in general, much less how to optimize their milk supply with pumping. And then by the time they can kind of adjust to the reality of having a preterm baby and turn their attention to themselves, because usually our mothers are just so concerned with their baby, they're already hours and days into the process, and it just makes establishing lactation that much more difficult. And lactation support offered to parents is also quite variable to various systemic strains, including understaffing and underfunding of lactation care, difficult sometimes to get outpatient lactation care, even inpatient lactation care. Parents may visit at 2 a.m. And they may not have access to the resources they need at that time. And the needs of NICU parents and special lactation support is really specific, and it's different than a term infant. And then outside of barriers that sort of directly affect families in the hospital, there's lots of systemic barriers as well, including sort of the lack of paid parental leave policy and financial burdens on families. They have to come back and forth to the hospital. They're frequently buying meals. They have to be able to pump and bring their milk. And all of that just adds a lot of stress and a lot of barriers to our families. Next slide. So sort of given all of these reasons, it really is difficult for every premature baby to have sufficient access to mother's own milk. So if it's not available or it's insufficient, there are really two alternatives. One is formula, which is typically made from cow's milk, or the second is going to be donor human milk. So for the purposes of this talk, I'm going to be primarily discussing pasteurized donor human milk. We'll go over a little bit of the different sort of milk processing techniques in a little bit. But pasteurized donor human milk is milk that is donated by mothers who have been screened and medically cleared by their doctor and the baby's pediatrician to donate milk. The milk of several donors is then pooled, it's pasteurized, and then it's post-pasteurization tested again for bacterial contamination. It's labeled and then frozen and then shipped to hospitals, usually for in-hospital use, but to a lesser degree to the outpatient setting. So the Human Milk Banking Association of North America, which is also called HMBANA, is the major nonprofit organization that oversees nonprofit milk banks in North America. There are currently 31 nonprofit or HMBANA milk banks. In addition, there are also commercial entities that serve as milk processing centers. And these for-profit organizations may compensate their donors or provide preferred pricing, on their products to hospitals that facilitate donation. So what are the benefits of donor human milk? So a few slides back, I showed the benefits of mother's milk to very low birth weight infants, including improvement in neurodevelopmental outcomes, lower risk of NEC, late onset sepsis, BPD, and ROP. Excuse me, but not all of those health benefits actually translate to pasteurized donor human milk. So it's really important to keep in mind that these are two different feeding products. I mean, these are two separate things. Mother's milk is one entity and donor human milk is separate, and they have separate benefits. But the one health benefit that really does translate is a reduction in necrotizing enterocolitis. This figure is a forest plot from the most recent Cochrane review, which was in 2019, that shows the results of multiple randomized trials that are comparing donor human milk to commercial formula for preterm infants. Just to orient this image, each line with a blue box represents an individual randomized trial. The line down the middle represents the point at which there is no difference between the two exposures, so the first exposure being donor human milk or formula. And then the diamond at the very bottom in the blue box represents the final combined results of all these studies. So as you can see, this final diamond, this black diamond at the bottom, falls fully to the right of the line. And this is the side of the line that demonstrates that donor human milk decreases NEC risk. Next slide. So probably the study that mirrors the most typical contemporary practice is the Domino trial from Canada. This is the top trial in this slide. The primary outcome of this study was looking at neurodevelopmental outcomes at 18 months in infants who were fed donor human milk with a bovine fortifier if mom's milk was insufficient compared to infants who were fed formula when mom's milk was insufficient. And this study actually showed no difference in neurodevelopmental outcomes between the two groups, but there was a reduction in necrotizing enterocolitis, both in all stage as well as stage 2 or greater NEC. And then the other benefit that has been shown in some studies is that by providing donor human milk and making it available, you actually do increase the proportion of feeds that are maternal milk. So the second study on this slide is a 2016 review of over 40,000 infants, VLBW infants from California, that found that increasing donor human milk availability is associated with increased breast milk feedings at NICU discharge, as well as showing, again, decreased NEC rates. Of the 22 hospitals that had a sort of clear transition to having the availability of donor human milk, there was a 10% increase in breast milk feeding at NICU discharge and a concomitant 2.6% decrease in NEC rates. Next slide. So I think some of besides the direct sort of more easily measured health benefit of decreasing NEC, there are other benefits to think about. If your unit is using donor human milk, naturally conversations are happening around the value of breastfeeding and the value of breast milk. And so this promotes a culture that values breastfeeding. And this culture shift can have lasting impacts for infants and their mothers. Providing donor human milk as a bridge can increase breastfeeding and provision of mother's own milk, as we've seen in several NICU discharge studies. And then sometimes mothers whose infants receive donor milk, they see and understand the value of that donor milk and go on actually to become milk donors themselves once their supply is in, which is a great way to give back. There are some important differences. I probably should have said differences on this slide instead of drawbacks, but some differences to donor human milk. As I said, it is not the same as mother's own milk. I do think in some of the tiniest babies, if donor human milk is used as the primary diet, and here we're talking about babies in the NICU, there are concerns that growth, there is some reduction in growth. It does not have the neuroprotective effects for preterm infants that mother's own milk does. So that so far hasn't shown to translate. And then it does require setting up a program. There's cost to that program. There's tracking of milk. There's freezing of milk, administration of milk. And so there is cost there to doing that. Next slide. So sort of comes down to this question, who should get pasteurized donor human milk? The best studied population is the very low birth weight population. So this is the group of babies typically less than 32 weeks and 1,500 grams for whom we have randomized controlled trial data that show a direct health benefit of decreased rates of NEC if pasteurized donor human milk is used if mom's milk is insufficient or unavailable. So that's where, at this time point, the most solid evidence exists. But there's other populations for whom donor human milk has been used in. So if you look at the group, the term infants or the late preterm infants who have specific health risks, there is some observational data here, as well as new and evolving randomized trial data. So in the cardiac population, there is observational trial, there's sort of observational data, so retrospective data looking most specifically at those with the single ventricle physiology, and then a recent 2022 randomized control trial that looked at a variety of factors in terms of feeding babies with single ventricle physiology, but of which donor human milk was part of that. And these have shown a reduction in NEC in this population. And this is another population of babies who are at high risk for NEC and have a very high NEC rate in addition to our VLBW infants. In terms of babies with GI anomalies, there's, again, observational data for decreased lengths of stay and decreased CVL days, specifically in babies who have small bowel atresia and gastroschisis surgeries. So not in the full spectrum of GI surgeries do we have data yet, although, again, there are ongoing trials in this, and there's ongoing randomized trials looking at this group of babies. And then again, there's some observational data in neonatal opioid withdrawal syndrome showing improved feeding tolerance. And I think there's going to be a lot more coming out in populations outside of the VLBW group, looking at the use and benefits of donor milk. So what about healthy term babies? Most of the data in healthy term babies is really establishing use, and so who's getting it. And there's really a lot less evidence in terms of tying it to a direct health-related outcome. And that's just where the evidence sits right now. So there are commonly reported use cases in healthy term infants include hypoglycemia, hyperbilirubinemia, excessive weight loss, delayed lactogenesis for mom, SGA babies, small for gestational age babies, and then maternal infant separation. So that's what's most commonly reported in studies that report on the use of PDHM in the healthy term population. One way to understand if there are direct benefits for the healthy term population in terms of supplementation with donor human milk in the term nursery would certainly be to look at the impact on breastfeeding. And here the data is a little bit mixed. There's observational data that shows a positive impact on breastfeeding at nursery discharge or at 6 months postpartum, so higher breastfeeding rates in infants who are supplemented in the term nursery with donor milk versus formula. And then there's small, again, these are relatively small trials, but there's small randomized controlled data showing no improvement or no difference in breastfeeding rates at 3 months, whether you supplement with formula or you supplement with donor human milk. I think this can go back to that sort of intangible benefit that I talked about a couple slides back, that if donor human milk is available or is at least being talked about, you are hopefully creating a culture that supports breastfeeding. All right, next slide. So are there different types of donor milk? Until I kind of got into this, I did not realize that there were. But over the years, as I've gotten to know my colleagues, Claire specifically, I've learned so much more about all of this, and it's all very interesting. So yes, there are different types of donor milk. So pasteurized donor human milk can typically come from one of two places. So Humbana, that we already talked about, this is a nonprofit organization that has milk banks throughout the country. The Humbana process is Holder pasteurization, and they have published guidelines on their procedures and how the milk is handled, pasteurized, and tested. Pasteurized donor human milk can also come from for-profit milk processing centers. They also use a pasteurization process, although the specific details are proprietary, but it is typically a little bit higher temperature for a little bit longer period of time. There's what is then referred to as sometimes shelf-stable milk or retort sterilization. These are also for-profit milk processing centers. They use a very different process than the Holder pasteurization process. So this is very high heat and high pressure for sterilization to make the product shelf stable, not requiring freezing. And then, as we already talked about, just so when you are talking with families, you are being very clear, don't forget that there is community or informal milk sharing. So this is unpasteurized milk that may come from the community. Next slide. This table, I will caveat, is from Humbana, so you should take that with that knowledge in mind, but it does outline two studies that looked at the differences in bioavailable factors in donor milk based on how that milk is processed. And so the summary of this slide is that the Holder pasteurization process, so all attempts to pasteurize or clean milk are going to alter the milk to some degree. But the Holder pasteurization process seems to hold on to more bioactive and bioavailable components of milk than does the sterilization process. And that's kind of the point of this, is that there are differences, although the milk seems to have less difference when Holder pasteurization is used versus the sterilization process. So next slide. So do these differences matter? I think on some level it's going to be a question mark, but I think it's really important for you to know, and especially as you're talking to families about the use of donor human milk, is that the trial data is using pasteurized donor human milk, not shelf-stable milk. So the trials are usually using milk, typically from Humbana milk banks. There's obviously some trial data in the for-profit centers, but this is all pasteurized milk, not shelf-stable milk. And the benefits of neck reduction is specifically documented with pasteurized milk, not shelf-stable milk. And this has a biological plausibility, as the previous slide showed, that the sterilization process may result in higher loss of bioactive factors. And then this can translate into different health outcomes. So we think we still have to be very careful what milk is being given to the fragilest, our smallest babies. Next slide. So really briefly, just a couple slides on the donation process in case you're interested. Essentially, moms go through a pretty vigorous screening process, and they have to be cleared by both their doctor as well as the baby's doctor. There's a verbal screening and a written screening, and then the donor qualifications are really adjusted as data changes. And I should caveat before I go through these next couple slides, this is mostly based on the Hambana process. Okay, next slide. The donors, as we say, they've got blood screening, so they're checking for bloodborne pathogens, things like HIV, hepatitis B, syphilis, and other viruses. There's medical releases and consents that are obtained from their healthcare provider. But then once the donor is qualified, they can donate in one of two ways. They can bring extra frozen milk to a depot, or they can ship the milk or deliver it directly to a milk bank. Next slide. So Georgia doesn't have a milk bank yet, but there are several depots here, and Claire has made a really nice map of the state with some of the depots that'll be on the next slide. And so moms, again, they can drop off at a milk depot, or they can ship it directly to the milk bank for further processing. If they want to just do like a one-time donation, they can do that, or they can do ongoing donations. If they're continuing to lactate and produce milk, they can absolutely do ongoing donations. And then the next slide, thank you, Claire, for putting this together, lists the different milk depots that exist in Georgia. And Claire actually has like the volumes of milk that all of these different depots have collected, and it's really pretty phenomenal. So it's great. And then underneath each of the named places is the milk bank that they are associated with, and where our moms in Georgia are able to ship and donate their milk to, which is wonderful. So before we move into the last section of this talk, I just sort of in this slide briefly translated some of the donor milk policies that are currently present in GaPQC. Obviously, there's no way to present everyone's policy, so I was just trying to summarize it. But what most hospitals reported in terms of who they provide donor milk to, most hospitals report offering it to infants less than 1,500 grams and or less than 32 weeks gestation at birth. But there's some variation here. So some will provide only in infants less than 1,000 grams. Some will provide in less than 1,800 grams. Some use a cutoff of 33 weeks. Some use a cutoff of 34 weeks. Some policies have a physician discretion or provider discretion sort of caveat. So they recommend for less than 15 and less than 32, but there's a caveat that, the provider can make a different decision. Some identify certain risk factors, such as small for gestational age or abnormal Dopplers, or asphyxia or history of NEC, that would then allow for the use of donor milk. In terms of the hospitals that told us a little bit about their term policies, some of the common use cases were very similar for what's been published in the literature in terms of weight loss, hypoglycemia, hyperbilirubinemia, and a couple will offer it at the parental request. I think a little bit less is known about when to transition babies who are receiving donor human milk off of that and onto formula. And so some of the reported time periods of transition was at 32 weeks, 34 weeks, 35 weeks. Some hospitals reporting transitioning once the baby reached 2 kilos, some at 1,800 grams or greater than 1,800 grams, some once they're greater than 1,500 grams. And some once the baby has reached full oral feed. So sort of a wide variety of approaches, with our hospitals. So sort of with that in mind, and that's kind of what we know, I'm going to turn it over to Kimberly to kind of introduce the panel, and then we'll move on with discussion.
Great, thank you, Dr. Rose. So up first on our panel, we have Michelle Pratt. She's Unit Director, OB Education at Emory Decatur Hospital. Michelle Pratt, she, her, is a registered nurse certified in maternal newborn nursing and obstetric and neonatal quality and safety. She has been working with birthing people and their families in various nursing and leadership roles for 12 years, inspired by her passion for reproductive justice and health equity. Most of her career has been spent at Emory Decatur Hospital, formerly DeKalb Medical. In her current role as Director for Lactation and OB Community Programs at Emory Decatur, Michelle led the team to a successful baby-friendly redesignation, established a milk depot for Mother's Milk Bank at Austin, and stood up a lactation follow-up clinic with virtual and in-person visits. She enjoys learning from breastfeeding experts in the community and seeks to always apply an equity lens to her hospital team's breastfeeding quality improvement initiatives. Dr. David Levine, who you all know as the GaPQC Neonatal Committee Chair, is a neonatologist and Director of Newborn Services at Piedmont Columbus Regional Hospital and the Regional Perinatal Center Director as well. His clinical interests include respiratory care and nutrition, as well as his long-standing interest in quality improvement. He is also Associate Professor of Clinical Pediatrics at Mercer University School of Medicine. Dr. Ravi Patel, who you all know as the GaPQC Neonatal Co-Chair, is the Associate Professor of Pediatrics in the Division of Neonatology at Emory University School of Medicine and a neonatologist at Children's Healthcare of Atlanta. Dr. Patel's interests include clinical research and quality improvement. Dr. Patel received his medical degree from Medical College of Georgia at Augusta University. He then obtained his Master of Science in Clinical Research as well as his fellowship training in neonatology at Emory University School of Medicine. Dr. Patel has special research interest in necrotizing enterocolitis and is on the Scientific Advisory Council of the NEC Society. Dr. Taryn Fairley practiced general pediatrics and breastfeeding medicine at Kaiser Permanente. She is a member of the Academy of Breastfeeding Medicine and adjunct faculty at Emory University School of Medicine. She currently serves as a physician chair of the EPIC Breastfeeding Committee at AAP Georgia and is a chapter breastfeeding coordinator. Take it away, Dr. Rose.
Awesome, thank you. And so we have prepared a couple of questions that we'll kind of go through in the panel, but please put questions in the chat as well if as more come up. And we did sort of intentionally try to give ourselves plenty of time to go through this. And Kimberly and Claire, if y'all don't just help mind monitoring the chat too, to make sure I don't miss anything, that'd be awesome. I don't know. We'll start with question one, but I'm sure there's going to be lots of interest in the term population, which we're going to get to. So I probably should have started question one with that. But so for preterm infants or low birth weight infants who require supplementation with donor pasteurized human milk, at what gestational age or weight do you transition to formula? And Dr. Levine or Dr. Patel, I don't know if you want to start with.
Sure.
With some of those.
Sure. We initiate under 1,500 grams, and we will generally supplement until 34 weeks. On occasion, there are babies who get supplemented beyond 34 weeks if they have particular nutritional problems and their mothers aren't providing milk.
I'm curious, Dr. Oh, sorry. Sorry, Ravi. I was curious, Dr. Levine, if you ever see transitioning earlier or issues with weight in babies who are primarily getting all donor milk. Does that ever move your hand to do something different?
It's funny that you asked that because I did that just over the weekend. Yes, it's a recognized phenomenon, and we have seen it on occasion, just on occasion. And so, yes, we have moved them. We have moved them to either to mother's milk, either to formula.
Sorry, Ravi, I didn't mean to cut you off.
And thanks for the great presentation. I would say our approach is similar. You know, the kind of rationale for use of donor human milk in this population is prevention of NEC. And so I think the transition is really based on when we think these infants are out of the kind of high risk window, which typically is, you know, around 34, 35 weeks. But as you showed from the data from our own hospitals in Georgia, it's really quite variable. And I don't think we have a great exact time point of what the best timing of transition is. But I think that's kind of a rationale around 34, 35 weeks is when the risk starts to go down for NEC.
And we certainly don't have enough data of our own to change that.
Yeah, and there's not a lot of guidance. We all have our N of ones. I'm on service right now and have a baby essentially corrected to 37 weeks now, that we're considering NEC diagnosis and had been transitioned. So it's always hard to navigate that. And if there are any comments from folks listening about when they transition, or questions about that, please definitely put them in the chat. We'll keep going through our panel questions and then address things in the chat as they come up. All right. So what about staff education? I think this is a really important point. We all know that having everyone who interfaces with mom and baby, with parents and baby, whether it be in the NICU or be in the nursery, on board and supporting a strong breastfeeding education. So what type of staff education is in place regarding the use of donor human milk? And Michelle, I don't know if we can start with you in terms of what you do at Emory Decatur and what that looks like.
Sure. I think staff education is a really important piece, to have them understand really where this donor milk's coming from, why it's important, and also, especially in the term population, the need to keep up building mom's milk supply as we use this as a bridge. So those are the things we've focused on a lot here. Some of the education comes from information directly from the companies, from the vendors. We've also had our staff, some in the NICU, worked on a project to really develop a robust brochure that the staff would kind of learn from first in the benefits, so that they kind of had the scripting and the information that they needed to be able to discuss it with the parents, because it's really the frontline staff that are having a lot of those conversations, and making sure that they understand not just kind of the clinical pieces of it, but also are able to answer parents' questions as far as what to do when they go home, how to transition back, and how to make sure that we're not that we're just using it as a bridge, and we're not cutting off their milk supply. It's not a replacement; it should be a support.
And Dr. Fairley, I know you do so much in supporting our moms in breastfeeding. I don't know if you have some comments on this, as you are frequently seeing, the babies with the most need in terms of their help with breastfeeding.
Yeah, no, there's a lot of relief on the part of parents who do come out of NICU, because I see them once you guys send them home, about that bridge to a good start, and getting to the office. And I agree that a coordinated approach to discussing donor milk is incredibly important.
When we're talking about education, I know a lot of the folks on here are nurses and lactation consultants and so forth. But when we're talking about education, it's really important to educate the docs and the nurse practitioners as well, because they're critical in this process. And it takes the team to lift, and if somebody's not carrying the weight, it doesn't get lifted as high.
Right, because if your doctor doesn't talk to you about it, like, does it really matter? Right? If we're not mentioning on rounds, if it's not part of rounds, if it's not part of our conversation with families.
Or if the nurses have forgotten about it, somebody else needs to be there to get it going.
And I certainly think we could apply this to, in our prenatal education, moms who are at very high risk, of preterm delivery, or for whatever reason, obviously general breastfeeding education, but introducing this idea, as well in that earlier setting. Sorry, just reading a couple comments in the chat. So let me let me switch over to these real quick, and then we'll come back to the sort of panel questions. From Dr. Deepa, should we find a lot of our term infants use donor breast milk for adopted infants or surrogate carriers? And I'm curious, along with Claire, Dr. Deepa, if this is policy-based. Okay. Can you tell us a little bit more about the policy for your term in nursery?
Sure. I mean, I misspoke when I said a lot of infants. The few infants who I have come across here who have ended up with donor breast milk are the adopted or surrogate carried. And I think this came as a policy or was able to be used just recently, only for the past few years. I don't think before we were really using donor breast milk for term infants, but it came about when we had a couple of these parents, surrogate or adoptive parents wanting to use it. And so now we have it so that if they want it, we can try and get it, and we have to have them sign a consent and things. And I think the cost, I'm not very clear about the cost thing, but I think there is some cost sharing involved because it is expensive that, these parents do pay some of the costs like that. But we have had a few, and all of them have been cases where they're surrogate carried or adopted infants.
That introduces an interesting dynamic where educated families who have means are requesting, but a lot of people in their demographic would consider the cultural norm, which I consider the cultural norm for our species, right? And yet for other term infants, we're not offering this. Correct? I mean, as the bridge, we don't always offer it by request.
Yeah, it definitely brings up that question or that, but again, if they know about it and they ask for it and it's there, I guess the question is, is it okay? Is it not? Right now, we're using it we have used it for a couple of these parents.
So I can speak to that because we do offer it because of the precise thing that Dr. Fairley was mentioning. When we first started offering donor milk, it was a similar scenario where it was a small group of patients who would prefer for their baby to go to the NICU and get an IV than to get formula. They were very educated on breastfeeding and were very intent on breastfeeding. And so as a mechanism to keep babies out of the NICU, we started case by case offering it to those families that were really adamant about not getting formula. And then through a lot of the equity work that we're doing in the maternity space here at the hospital, it really brought up exactly what you said. This isn't an equitable way to use donor milk. This isn't fair. This is perpetuating disparate outcomes if we know that outcomes from breastfeeding are so much better. So we really stepped back and made it for any parent who intended to, exclusively breastfeed while they were here. If they needed formula, they asked for formula. We would do what Baby Friendly tells us, which is the preferred supplement in that case is first express breast milk and second donor milk. So we would offer them donor milk and talk about this is what's available. And what we saw, because a lot of times it comes up, well, do different people or do different populations not want to use it? But when we offered it equitably to everybody, among our Hispanic and our Black patients, we saw significant increases in the amount of use by it. So once we were being equitable, we had more equitable outcomes in the use. So I think I'm glad you brought that up. I think that's really an important point.
Yeah, and World Health Organization has always maintained that that's the process, right? Like that we have, expressed parents' own milk, or if we don't have that available, that we use donor human milk. And they don't differentiate between resource poor and resource rich settings. Right, that is simply the desired supplement. It depends what you think of as the norm. I no longer deign to justify why I need to use human milk. It is the norm for our species and should be our baseline. And any deviation from that is what we should justify.
Michelle, do you have any idea of about how much, I mean, many term infants who may need supplementation may not actually need a lot of volume. I was just curious if you have ideas on actually how much is used.
I mean, I don't have those numbers off the top of my head, but what we do we use the shelf stable pouches on Mother Baby, so they'll kind of basically aliquot those into 5 and 10 ml syringes. So a lot of folks will just get it for hypoglycemia or some sort of issue where we're saying there needs to be a supplementation. We do have some folks that are maybe really struggling with milk supply or with latch, and they may get a little bit more, but it's limited. It isn't all. The most cases, it's not over and over and over again. Some babies do tend to use it the whole time we're here, and that's where I think we get into those challenges of making sure that our lactation staff are engaged and helping to correct whatever the issue is or work towards resolution of whatever the issue is that's requiring this supplementation.
Thank you. While we're on the education question, even though we've moved on a little bit, and a question in the chat is, what options do you have for education in the community for parents and for families? I'm not sure who wants to tackle that one.
I mean, it's an interesting point, right? And in terms of discussing the equity angle, like Michelle was saying, like maybe this is something we should take to community leadership and start talking about donor human milk. Who gets it? I'm not aware of any larger campaigns though. Michelle, do you guys have any outreach that you guys do?
I mean, no, we do like a virtual tour. So we mention it in there that it is a resource that's available once you're here. Unfortunately, the percentage of people that actually sign up for the tour compared to the number of deliveries we do is low. But that's really been our only mechanism. And then I guess, word of mouth from patients that have delivered here. We have had people say that they heard from their friends that, it was an option, but we don't have a formal mechanism.
Thanks. All right, let's see what question 3 is. I say, what about consent? So this is probably an interesting one too, depending on sort of what lens you're going to look at this. So what consent process are in place in the hospitals? And again, we could talk about the different settings that we're going to interact with this, whether it's in the healthy newborn nursery or in the NICU. Do you use an opt-out consent? And if so, what does that look like? Dr. Patel, you want to?
Yeah, for our NICU, we currently get consent, although I would say that the consent rates are incredibly high. So it's very uncommon for kind of after for refusal of consent. And occasionally when there's refusal of consent, I think that's followed with a discussion. And once you actually kind of go through the alternatives and the data, I think sometimes the initial refusals actually, once they understand the benefits in the preterm population, they actually consent. So, but we do get consent at both of at all of our hospitals that use donor human milk.
Okay, and I know some folks are using an opt-out version as well.
A lot of places have moved to opt-out, and we might do that, but Piedmont limits us at this point.
Okay, so obviously all of these things are nuanced by working with hospital boards and other folks who are involved in setting policy. We are getting on towards 3 o'clock. So I know despite the fact that question 4 gets back to the term infant, I do want to make sure that we get to the last couple panel questions. So Kimberly, what if let's go to 5 real quick. So our hospital doesn't have donor milk available, but we're interested. Where do we start? Does anyone, have any of y'all actually done the work to set up the donor milk program at your hospitals? And can you offer some suggestions here?
I'm going to make a shameless plug for GaPQC. This is exactly the intent of having collaboratives with many different hospitals across Georgia, so we can help you at a hospital. So if you're one of these hospitals, one of our goals is to be able to connect people with hospitals that have done that. So please reach out to Kimberly. I know we're kind of ending on time, but there's a lot of experience from different hospitals that have gone through this process, both in the well newborn and the NICU setting. So I would make sure I mention that.
Right. So there would be a lot of help with policy, both policy and process.
Right. Yeah. There's, I think, as Dr. Patel said, the whole point of this is to collaborate and to use shared knowledge and to not make anyone reinvent a wheel. And so there's lots of people who have done that and can help. And there's wonderful resources. So if you don't have one and are interested, definitely reach out. I'm just trying to skim the questions in the chat. And we talked about education in the community. So there's a question about introducing the idea of donating to mothers whose babies have passed away during the delivery or in the days after the delivery. And that is obviously a very tragic and difficult situation, but yes, bereaved donors are definitely eligible to donate. And it sounds like the folks at Atrium have it in their bereavement package. So I'm not sure how other hospitals address that with their families, but that is oftentimes a way that parents want to honor the memory of their child.
I'm sure everybody's aware, but just in case anyone isn't, there is Medicaid payment for donor milk. It's a process, like anything to get paid, but if that's any kind of barrier for anyone, it probably doesn't be.
Yep, and we worked hard to get that, and it's still in the phase. The money is there, it is slotted, and the hospitals do need to submit, and we just really need folks to start submitting their claims so that we can start to work out any kinks and making sure hospitals are submitting claim and getting reimbursed. So, it is for the inpatient setting, but perhaps more work to come on that later.
And thank you, Allison, for your role in getting that passed.
And Claire and Robbie
Claire,
and everyone. Great. And Deborah Bolden, thank you so much for your comment in the chat. You work closely with the infant feeding room and order the donor milk for your program. If anyone would like to contact me, we've had our collaboration with King's Daughter Milk Bank for 7 years. So that's great. Thank you. I appreciate that. Okay.
I'd like to just say one thing. If you look at our GaPQC report, we're still, one of the areas I think for improvement is as you think about formula supplementation in the last week and you're doing audits, ask why. Why did those infants get supplementation, and could that be an opportunity in the various settings you're working on of considering that? I think that would be a take home, because that is one of those measures where, as Dr. Rose nicely pointed out, was where I think we have a lot of opportunity across the state in moving the needle. And we if you look at the last 6 months of data, we're still at about 60% formula supplementation the last week in our various settings. So I think that would be one area as we think of improvement, to just kind of ask the question of why, and maybe that will help you think about opportunities there are for this, as Michelle Pratt nicely kind of shared their experience at Emory Decatur.
Well, Kimberly, I don't know. I think we'll pause there with the panel questions. I don't know if you want to take it over to put up the QR code and send us
Sure,
all off.
yes. Yes, thank you to our panel. Thank you, Dr. Rose, for your presentation and for moderating the panel. That was excellent discussion. I'm sad that it has to end. Probably could continue. So I did wanted to share, there is an EPIC. This, I think, this was mentioned a bit in the panel with treating for hypoglycemia. And so this is, if blood sugar is one of the reasons your hospital is supplementing breastfed newborns with formula, or if you'd like to get up to date on evidence-based practices around managing hypoglycemia, you can register and attend the upcoming EPIC breastfeeding education webinar, which is breastfeeding and hypoglycemia, the highs and lows. It's free to healthcare providers living or practicing in Georgia, and continuing medical education is available to those who attend live. It'll be recorded and available in the free EPIC on-demand library for those who cannot attend live. And I'll make sure, Claire just put it in the chat to register for this EPIC. It'll also go out in the follow-up email, so you'll have all of that in one spot. And a couple of reminders. The February audit will go out Monday, the 20th. So if data leads, look out for that. Your driver diagram is due March 1st. Again, reach out if you have any questions about that or your SMART aim. And there's no March webinar. It is at the same time as the Emory Conference on Breastfeeding, so please consider attending that. And again, the information on sponsored registrations will be in the follow-up email. And here's your QR code, so scan that, or I will, it's not letting me copy the thing. I will figure out how to copy the link, and I'll drop that in the chat if you need it, and you can register to show that you attended our webinar. And thank you, everybody. Get this.
Thanks, everyone. Thanks for all the great comments in the chat.